Welcome everyone to today's Medicaid Section 1115 Learning Collaborative webinar on how states can plan for and implement the transition to the latest edition of the American Society of Addiction Medicine, or the ASAM criteria in their Medicaid Section 1115 demonstrations. CMS is pleased to have attendees from state Medicaid agencies, state contractors and consultants, and independent evaluators here today. We appreciate your attendance. Your continued engagement is critical to advancing high-quality, evidence-based care for individuals with substance use disorders through Medicaid Section 1115 demonstrations. And we're especially appreciative of our state presenters from Colorado and Kentucky. We look forward to hearing about your experiences as you implement the ASAM criteria and learning from you today. Section 1115 substance use disorder, or SUD demonstrations, often integrate the ASAM criteria in demonstration design to ensure access to a range of appropriate services and appropriate placement for addiction treatment. The release of the fourth edition of the ASAM criteria in late 2023 represented a significant evolution in the ASAM framework, with a much stronger emphasis on integrated and person-centered care. As states begin to explore and adopt the fourth edition, it will be important to understand the implications for demonstration planning, provider readiness, and monitoring and evaluation. CMS remains committed to providing technical assistance and fostering collaboration across states to support innovation, flexibility, and continuous improvement in SUD treatment. While adoption of the fourth edition is not federally mandated, and there is no official timeline by which states must begin aligning with the updated criteria, CMS supports states in incorporating evidence-based practices that improve care delivery and outcomes. Next slide, please. During today's event, we will discuss the webinar objectives, provide an overview of the ASAM criteria. We will also hear from speakers from Colorado and Kentucky, states that are well into planning and implementing their transitions to the fourth edition ASAM criteria. From Colorado, we are joined by Kristen Bates and Jennifer Holcomb, who are experienced in leading statewide behavioral health transformation. Their roles span policy development and benefit design for mental health and substance use disorder services. We will also hear from Dr. Leslie Hoffman, Sarah Johnson, and Angela Sparrow from Kentucky. They bring deep expertise in statewide behavioral health strategy, policy, and implementation. Their roles include Medicaid leadership, substance use disorder program development, and Section 1115 demonstration management. After the presentations, we will also hold breakout sessions to dive deeper into key subtopics. This will be a chance for attendees to connect in smaller groups, share experiences, and discuss among peers. We will include time for questions after each state presentation, so please feel free to add your questions to the Q&A widget as we move through today's event. Next slide, please. The objectives for today's webinar are listed on this slide. Today's event is designed to be a collaborative space for sharing experiences, identifying challenges, and highlighting promising practices that can inform future work. We encourage you to actively participate in today's discussion through Q&A and in the breakout sessions. In alignment with that, these are the objectives that we have for today's discussion. Next slide, please. So first, we'll start with a little bit of information and discussion on the ASAM criteria. To ensure high-quality, evidence-based SUD treatment, CMS requires that states with SUD demonstrations implement policies to ensure and improve access to SUD services, including requiring that providers assess treatment needs based on SUD-specific multidimensional assessment tools. The ASAM criteria are widely used by states to meet this requirement. The ASAM criteria provide a set of nationally recognized evidence-based guidelines for assessing, treating, and placing people with substance use disorders. The criteria are developed by the American Society of Addiction Medicine, a leading medical society representing over 8,000 specialists focused on addiction treatment, and were first published in 1981. The first volume of the fourth edition was released in late 2023, the first update since 2013, and it includes standards and assessment criteria for adults with addiction and co-occurring conditions. Subsequent volumes of the fourth edition will be published over the next 3 years and will focus on adolescent and transition-aged youth, correctional settings and reentry, and behavioral addictions such as gambling, interest and gaming addictions, and sex addictions. Next slide, please. Providers use the ASAM criteria to guide level of care recommendations and individualized treatment planning. The criteria define a continuum of care that includes 4 broad levels across 6 dimensions of clinical need and functioning. Ultimately, the ASAM criteria are intended to promote holistic biopsychosocial care and help providers match patients to the least intensive but safest and most effective level of care. Next slide, please. At a high level, this update of the ASAM criteria from the 3rd edition to the 4th edition is intended to reflect current clinical practices and person-centered, recovery-oriented focus. This resulted in a stronger emphasis in the 4th edition on individualized care and a shift to more dynamic, flexible treatment planning. The dimensions have been updated for clarity and relevance and also reordered. In the 4th edition, the dimensions for readiness to change is now integrated across the dimensions and replaced by a new dimension, which is dimension 6, person-centered considerations. And this emphasizes care barriers, individual preferences, and the need for motivational enhancement and shared decision-making. Next slide, please. Let's now look at some of the key changes to the continuum of care in the 4th edition. The continuum includes 4 broad levels of care, as well as decimal levels representing further gradations and types of care. The updated criteria integrates withdrawal management services across the levels of care, providing medical management for intoxication, withdrawal management, and biomedical and psychiatric comorbidities into the continuum of care. The 4th edition also adds a new level, level 1.0, long-term remission modeling, intended to support individuals in sustained remission through recovery management checkups and rapid reconnection to care when needed. This change aligns with chronic disease management models as well. The updated criteria also include changes to the level of care that promote co-occurring capable care, access to recovery support services, and consideration of the harm reduction needs of each patient. Please note that the 4th edition of the criteria also considers the use of recovery residences, which are homes or home-like settings that offer opportunities for people to practice interpersonal and life skills. For some individuals with substance use disorders, the ASAM criteria may recommend a recovery residence alongside an outpatient level of care that is level 1 or level 2. Now, I'm pleased to introduce the first of today's state presentations with Kristen Bates and Jennifer Holcomb from Colorado. Kristen is the Office Director for the Medicaid and CHP Plus Behavioral Health Initiatives and Coverage, and the Deputy Medicaid Director at the Colorado Department of Healthcare Policy and Financing. And Jennifer is the Behavioral Health Benefits Section Manager at HCPF. I will turn it over to Kristen and Jennifer. Thank you all.
Thank you, Danielle, and good morning, everybody. My name is Kristen Bates, and if we can go to the next slide, and I think Jennifer's on camera as well. As Danielle stated, in Colorado, we have an Office of Behavioral Health Initiatives and Coverage within Medicaid. So my role is really to work with Jennifer on our 1115 waiver and manage all of our mental health and substance use benefit and policies. Jennifer, yeah, I think that's all for now. Jennifer, you want to introduce yourself?
Sure. Good morning, everyone. Happy to be here. I am Jennifer Holcomb. I have been working on our SUD 1115 demonstration for a little over the past 4 years. We are in our 5th year of our demonstration now, and I look forward to sharing some insights of what we've learned as we try to move to ASAM 4.
Thank you. We can go to the next slide. So today what we're going to talk about is a little bit on how Colorado is set up, so you understand kind of our Medicaid program. We're going to talk a little bit about how we've been preparing for the transition and what pivots we've had to make, as well as some key recommendations on how to stay on track moving forward. And go to the next slide. So when you look at the goals of our 1115 waiver, which is currently called the Expanding the Substance Use Disorder Continuum of Care in Colorado, these goals on the left should look familiar to any of you who've worked on an 1115, right? We are trying to increase identification of need and access to treatment. We want to make sure that people are staying in treatment and not readmitting. We want to make sure we're reducing the most adverse events like overdose deaths, as well as reducing emergency department inpatient hospitalization. A lot of times that means reducing overdose events as well, but also things related to substance use. We want to make sure we have an improved quality of care, and also improved access to physical health, because we know that substance use treatment is a part of holistic care, and that's an important part, not just for the individual, but also for Medicaid to manage costs of care, something that couldn't be more timely. So what does it look like here in Colorado? Okay, so Colorado has kind of a unique system. I mean, I think we all say that when we talk about our states. But for us, we have a managed care model that includes prepayment inpatient hospitalization plan, managed care entities that manage all of our mental health and substance use services. So our substance use, mental health, which we call behavioral health, those are all under a managed care program. And those managed care entities also cover primary care and case management. However, they do not cover physical health services. So we basically run a fee-for-service model in physical health. And then for behavioral health, we run managed care plus the care coordination supports of in those managed care spaces. So that means the providers, they enroll in Medicaid here at Healthcare Policy and Financing. We call it HCPF. And they enroll in Medicaid, and then they are required to contract with our managed care entities. This has been a really big part of our SUD model, because we've been relying very heavily on our managed care entities and partners to help us build out that network, and also relying on them to use some of their admin funding and community costs to try to help train providers, ensure that they're well prepared. When we first started, we had a number of, that was in 2021, we had a number of substance use facilities here in Colorado, but because there was no public payment, they of course were not really set up to accept Medicaid. But we have moved on to a place where almost all of our substance use providers, and that's residential and outpatient providers, are almost all contracted with managed care entities now, which is a huge benefit to the 1115 waiver from my perspective and from our members' perspective. This is making sure that we have those contracts has been really helpful in connecting folks to the care continuum. But one of the challenges that we found was that providers had been very siloed and separated in what type of care they provide. And so we didn't have enough providers that were really covering that full care continuum, from crisis and withdrawal management to residential, high intensity outpatient, and then outpatient and recovery. Of course, all of our reimbursements here in Colorado are based on ASAM levels of care. We can go to the next slide. So some of the key things that we put up in our plan was we had like kind of 3 elements. So the other thing about Colorado is that we have our state Medicaid agency. We don't have a single health authority. So we have our state Medicaid agency, and we have our behavioral health agency administration, which is separate. That's the single state agency for mental health and substance use. And then Medicaid, HCPF, is the single state agency for Medicaid. So it's been really essential that we work with the managed care entities and our provider partners in setting those regulatory standards, and making sure that while our licensing folks in the state of Colorado understand that relationship between cost and licensing, that's not always the case. Licensing, we had to make sure that all of those rules and regulations fit exactly with ASAM. And one of the big challenges that we're facing is, 4 years later, we're having to redo all of that licensing, hundreds of regulations that are being adjusted. Now, I don't think that the changes are always that significant, for example, in some of the 3.5, but we really have had some challenges in, like, we were trying to move forward and then we had to redo all the licensing, which takes another year. So I think that when it came to preparing our partnerships, fortunately, we had built up with our licensing partners, hey, this is why we have to have ASAM. This is why it has to match exactly. But the challenge was working with the substance use provider community and the managed care entities to make sure contracts were updated, to make sure, and then most importantly, to make sure practices were updated. And Jennifer's going to talk a little bit of what that looked like. Um, and and why we decided to change some of those directions during our process, that lengthy process of getting buy-in for rule changes. It's not just like you're changing one thing, you're changing a lot of things. That's been challenging. So I think that those are the key things to understand about when we're looking at preparing, making sure you have your managed care entities, your provider community, and your licensing agency all aligned with those Medicaid goals, when they might not even know what an 1115 waiver is, has been a really important part of gaining buy-in and moving forward. So with that, I'll send it over to Jennifer, who's going to talk to us a little bit more about the process.
Great. Thank you, Kristen. Let's hang on this slide for just a moment, and then we'll move forward. When we look at these building blocks here, our department, Healthcare Policy and Financing, has viewed that first block along the bottom as our cornerstone, and we see our relationship with the Behavioral Health Administration that Kristen was referencing as the core on which we've built our other relationships. They're responsible for oversight and management of our behavioral health strategy and regulatory oversight, where our department is responsible for the management of Medicaid behavioral health services delivered to members and our 1115 demonstration. On top of that, we've built our relationships with our regional organizations that help us in 4 regions of the state as those folks that ensure that we have networks to deliver services in all parts of Colorado to all Medicaid members. And then that final piece that is the most critical building block are the SUD providers in our SUD community of partners. And this group really is the group that needs to understand and implement all of the operational changes that we identify and define to ensure that their practices are using ASAM 4th edition effectively and successfully across all of Colorado. Next slide, please. Our overall timeline, we started the work when ASAM 4th edition was released. All of our providers said, when are we adopting this? So we started right in and saying, let's get this underway, and held lots of listening sessions saying, well, what would we need to have in place? And we learned relatively quickly that there are a lot of things we'd need to have in place. So we did begin with asking for feedback, and I'm going to focus mostly on what we learned as we asked for that feedback, but you can sort of see as you look through the progression. The punchline is, and the preview you see here is, we came to the realization that we thought we could do this by July of 2026. And we have recognized, as we've done more work together in partnership, that it is going to take us at least till July of 2027. And that extra year of actual implementation, we are hoping will help get us pushed over the finish line. Next slide, please. When we think about how we engage with providers, As I mentioned, we spent a lot of time asking for feedback, and we recognized fairly early in the process, looking at changes that fourth edition brought us, that there were a lot of changes that would impact our 3.2 withdrawal management providers specifically. So we did hold focused groups and listening sessions in collaboration with our behavioral health administration partners to try to understand the unique needs of that particular group. This led us to some critical insights, as I mentioned, that we need to slow down our implementation process a bit. We do have a variety of forums that are held jointly to talk with SUD providers in general and focus on ASAM implementation specifically. We do hold office hours for technical assistance, and we do try to post communications both through a web page and through newsletters. But even with all of that, we recognized the need for specific technical assistance and did work with HMA to help us develop a robust provider toolkit of self-evaluation tools and feedback surveys and educational content and guidance about each of the levels of ASAM-4, and to provide some crosswalks of how different level providers under third edition would need to change as they considered what level they wanted to move to in fourth edition. Let's go ahead to the next slide, please. So when we started thinking about how we could use data in terms of making changes and coming into alignment, we really looked at 3 areas that we could use information to make change. The foundational changes to policies, rules, and reimbursements are the first set of changes that we identified. The second set were structural changes. And what we mean by this is changes we would need to make to our networks across the state and changes we would need to make to our infrastructure to support those networks statewide. And lastly, we identified operational changes. And these operational changes are at the practice and facility level. What would providers actually need to change in their most local context to deliver services in alignment with ASAM 4th edition as compared to what they're presently doing in ASAM 3rd edition? So with this, we identified that one of our key areas of concern is withdrawal management. And here in Colorado, our withdrawal management providers, particularly our 3.2 providers, did not have very well aligned and integrated services with other residential levels of care, high intensity outpatient levels of care. And we recognized that this group really was going to need support in determining how they might transition. And we also recognized that our other residential levels of care and high intensity outpatient, but particularly residential, that did not have withdrawal management already embedded would also need to make changes to come into alignment with those levels of care. How this impacts our regulatory transition work is the need to incorporate changes to staffing expectations for each of these levels of care across the ASAM continuum. And in some cases, this also means making facility changes to ensure that the physical layout and structure of a facility is equipped to handle withdrawal management as well as other residential level of care needs. On the Medicaid system side, our transitions recognize that since, as Kristen mentioned, in Colorado, our rates reimbursements align with current third edition levels of care, we would need to make changes to our reimbursement model to ensure that the new staffing changes and facility capacities align with the way that Medicaid is providing reimbursements to those new fourth edition levels of care. So, to make all of this work together, this requires close coordination and strong relationships between the provider community, our organizations, our regional accountable entities, and behavioral health service organizations that manage networks, and both the Behavioral Health Administration and HCPF. Lots of coordination. Next slide, please. So let's talk about some of the lessons that we've learned in the last couple of years as we've been working through this. Collaboration has been a huge benefit, and having as many channels of communication as possible, both virtual and in person and in writing, is beneficial to all. Having training and technical assistance materials that individual providers and interested advocates can access to learn and read more about has also been really beneficial. Even with all of this in place, challenges that we faced and continue to work through are supporting providers in being ready for this change. In the current workforce environment, supporting providers and having the necessary staff to deliver all the services required in each of the fourth edition levels of care is a real and continuing challenge. Supporting providers in building capacity and building infrastructure is also a challenge that has continued and perhaps even increased in difficulty as continued changes to Medicaid come out in the current financial climate that we're in. Not just for Colorado, but definitely seeing that impact. When we evaluate the changes that we make, the integration of medication-assisted treatment in particular as part of the services that are covered does require a more medical component, and that is one of the specific and unique challenges that we need to continue to think through and address. Next slide, please. So when we considered what our options were and explored what our path forward might be, we considered a phase-in approach versus what we would call a big bang approach of make all the changes at once. And we did determine that making all the changes at once and laying out the pathway and taking the time to be prepared to make all of the changes at once is what would work best for Colorado. So part of our slowdown in a start date is trying to ensure that we are ready for that big bang. The next category that we considered was the issue of withdrawal management and teasing apart what social detox historically is meant in Colorado and the difference of engaging members in withdrawal management as part of their treatment versus managing detoxification when an individual needs that particular service. We often have the experience of individuals being picked up by law enforcement or could be family member and dropped off somewhere intoxicated, and that person may or may not be ready to engage in treatment. So figuring out how to manage and distinguish between that engagement and treatment versus the safety issues related to detox is something that we've looked at in our crisis services space. And we are going through a process of exploring the rollout of a behavioral health urgent care model that may include that particular service outside of the scope of engaging in ASAM level of care treatment as a treatment choice to treat SUD. The next category that we worked through and contemplated was how do we fund the infrastructure changes and capital investment? As all of you know, we are not allowed under Medicaid to use Medicaid dollars to be building that infrastructure, making those capital investments. So in Colorado, we have explored the use of opioid settlement funds and other state funds that are available within Colorado to help support providers that need to make those physical changes to support more effective use of ASAM-4 in existing buildings and facilities where SUD services are being provided. And lastly, buy-in, and this is buy-in from the community at large, advocates, providers, consumers, members. How do we help folks understand the value, importance, and benefits of transitioning to ASAM-4? We've done a lot of stakeholdering and communication, and we'll continue to provide education to our partners. We collectively, as state agencies, both HCPF and the Behavioral Health Administration, recognize the benefits and value to delivered treatment that research supports and shows better results with the ASAM 4th edition approach, but bringing everyone along and supporting folks in moving there is a slow and expensive process that benefits from ongoing collaboration and support over time. With that, let's go ahead to the next slide. I will help us to wrap up with kind of our key takeaways. Our 3 R's, focusing on rules, regulations, and reimbursement, is an internal agency process. And then our 3 I's for a broader community is identifying barriers, building pathways for infrastructure, and investments. Thank you all very much for your time. Next slide. This is just our contact information that'll be available if you need to reach out afterwards. And I think that brings us to questions.
Yes, thank you so much, Kristen and Jennifer. It's great to hear about all of the work that you've been doing in Colorado, preparing for the transition to the 4th edition ASAM criteria. I'm Kavita Chowdhury with Mathematica, the contractor supporting CMS in this webinar, and I'll be facilitating some Q&A today. We just have a minute or two here for Q&A, so if there are any questions for Kristen and Jennifer, I'd like to open it up. And folks should feel free to enter questions through the Q&A widget as you might have seen the instructions pop up in the chat. So first question, are there, or sorry, how are you preparing for integration of youth levels of care, given that this text isn't yet published?
We are at present focusing on implementing for adults. We are awaiting the edition focused on youth to address youth needs.
And we have had a very difficult time in Colorado getting folks to open or retain substance use facilities for youth outside of the hospital setting.
Great, thank you for that. I am actually seeing no other questions at this time. Hopefully later in the webinar, we may be able to carve out additional time for questions if other questions arise for Kristen and Jennifer. So thank you once again to the both of you for your presentation. And now we will turn over to Dr. Leslie Hoffman, Sarah Johnson, and Angela Sparrow from the Kentucky team to hear about their efforts transitioning to the ASAM criteria 4th edition. So Dr. Hoffman, Sarah, and Angela, they bring deep experience in statewide behavioral health strategy, policy, and implementation. Their roles include Medicaid leadership, substance use disorder program development, and Section 1115 waiver management. So now I will turn it over to the Kentucky team.
Good afternoon. My name is Leslie Hoffman, and I'm going to go over the Team Kentucky Medicaid portion, our SUD demonstration for the presentation. Next slide, please. These are our presenters today. You may have heard us speak before. We're very proud here with our Team Kentucky that we're such an integrated state. And I want to speak to you today about our SUD demonstration and the transition over to the ASAM criteria 4th edition. Again, I am Dr. Leslie Hoffman. I am Deputy Commissioner for the Department of Medicaid Services. And I have with me my colleagues, Angela Sparrow. She's a technical project specialist with the Kentucky Department for Medicaid Services. And I also have Sarah G. Johnson, and she is the director of our Division for Substance Use Disorder with the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. As again, I said earlier, we are so very proud of our integrated state. Medicaid works very, very closely with all of our sister agencies, both inside and outside of our cabinet, such as the Department for Behavioral Health, who serves as our state mental health authority. So DMS and DBH, both of our departments, both fall under our Cabinet for Health and Family Services, which is CHFS. Next slide, please. So just for our agenda today, for today's webinar, our team is going to provide a brief overview of the state substance use disorder demonstration and our transition to the American Society of Addiction Medicine Criteria 4th edition. Kentucky will go over our approach that we have taken, such as provider training across the Commonwealth of Kentucky on the 4th edition. We feel that it's been instrumental really in ensuring the successful transition. We also will highlight some of the preliminary outcomes that we have here in Kentucky from the training thus far, and then we will wrap it up with lessons learned along the way. Next slide, please. Okay. Kentucky's SU demonstration was approved in January of 2018, and we received our implementation plan approval in October of 2018. Kentucky began its implementation in July of 2019 and received a 5-year extension through December of 2024. Kentucky's initial implementation included the adoption of the ASAM criteria as a standard when our SUD treatment across the Commonwealth started, and which we had started with the ASAM 3rd edition at that time. Coinciding with our 1115 implementation, Kentucky saw the need to standardize treatment and improve our quality of care. Medicaid and the Department of Behavioral Health, and as well as our Office of Inspector General, and various state agencies, included our managed care organizations. We have 5 here in Kentucky, our MCOs. We collaboratively joined together to develop a work plan that would support the improving access to the quality services across the state. This included us reviewing and looking at alignment across licensure and our Medicaid regulations to ensure ASAM criteria and the full continuum of services when we were looking. This work it built on the foundation to support our ongoing collaboration, our partnerships that we currently have today. These partnerships have been vital in supporting the transition to the 4th edition. During our initial implementation, Kentucky did strive to provide clear and concise guidance through regulatory oversight, and the state did include actually language that said the most recent ASAM criteria in policy should there be used in case we had future changes. The state could allow the criteria to be the guide for delivering the services with minimal changes needing to make or made in our regulation and our policy adoption for changes. This allowed for a timelier timeline, really, about our transition to the 4th edition a few years later when the announcement from ASAM was later made. Next slide, please. So our transition to ASAM 4th edition. Kentucky Medicaid transitioned to ASAM 4th edition July the 1st of 2025. Prior to that transition, Kentucky had leveraged ongoing partnerships with state agencies and our managed care organizations to support the work. As part of the initial demonstration, mentoring, and evaluation efforts based on partnership and feedback and technical assistance and assessment, Kentucky saw that we did have the need for additional training and ongoing support for our providers, our healthcare providers, our health plan providers, our agency staff, and our community regarding the ASAM. DMS did receive feedback and from our partners that additional training and awareness was needed prior to the implementation. DMS and DBH, our sister agency who oversees our Kentucky opioid response effort, and we call that CORE here in Kentucky, KORE, sought technical assistance through the Opioid Response Network, ORN, to help guide the state in identifying very specific needs pertaining to the utilization of the ASAM and to assist our teams in developing improvement strategies to support ongoing engagement. And also, we needed it to help empower and assure our organizational change management. Kentucky considered best practice approaches for engaging our partners and our providers. This would include surveys, focus groups, and we're going to identify our regional champions. Kentucky also considered tailoring the message to ensure buy-in, which is absolutely critical in supporting and maintaining this change. Buy-in is needed across our audiences, including our organizational leaders, our managed care partners, also our utilization management reviews, our clinical staff, and our paraprofessionals. This is also support. We need support for buy-in and ongoing change management. Kentucky understood it had a need, and it was clear and simple that we needed that going forward with the objectives for adopting the ASAM criteria 4, standardizing treatment, and how it would improve quality and access the full continuum of care here in the Commonwealth. As Kentucky was considering our strategies for improvement as part of the SUD extension, it learned of ASAM's intent to release the 4th edition. So while we were not While we did not stall any of our efforts, Kentucky did determine that it was probably our best approach at the time to align additional trainings and support with the release of the fourth edition and to evaluate the impact of those changes prior to moving forward with any additional activities. Our team continues to work together through the release of the fourth edition and to familiarize ourselves with the changes, evaluate our policy impacts, and to understand the needs of all of our providers and those that are involved and agencies to implement this new edition. While policy changes did require Kentucky to move forward with the transition earlier than anticipated, Kentucky does still continue to work to ensure that all information and support is always available. At this time, I will go ahead and turn it over to Sarah Johnson with the next slide. Thank you so much.
Thank you, Dr. Hoffman. So I'm going to talk to you a little bit about the ASAM training series that we developed and rolled out in Kentucky. So I'd like to start with a quick overview of the training, the fourth edition initiative, and how we're supporting training or providers statewide. Kentucky partnered with Hazleton Betty Ford Foundation, ASAM's national publisher and training partner, to develop a training series tailored specifically to meet our state's needs. The goal of this series was to ensure that clinical providers across the state had consistent, evidence-informed tools for assessment, level of care placement, and treatment planning. The ASAM 4th edition offers improved clarity and flexibility, helping providers make real-time, defensible clinical decisions. And through this training, participants received a clear, comprehensive review of the ASAM criteria 4th edition, along with guided preparation for implementation across different service settings. It also aligns with the goals of Kentucky's SUD 1115 waiver. Next slide, please. Our statewide ASAM training rollout uses a structured three-phase implementation model. All sessions are virtual and are led by ASAM subject matter experts from Hazleton Betty Ford Foundation. In the first round, we are offering 19 sessions, each limited to 50 participants. Continuing education credits are available to support provider engagement and participation. Phase 1 focuses on state and agency leadership. It provides an overview of key updates in the ASAM 4th edition and prepares leaders to support providers through the transition. This phase highlights system-level and policy implications to ensure alignment across state, payer, and provider systems. It also offers strategies for delivering technical assistance and building system readiness. Phase 2 is an extended training for clinicians and providers. It offers a deep dive into assessment standards, risk ratings, levels of care, admission and continued stay criteria, and implementation of best practices. These sessions are highly interactive and designed to increase consistency and quality across the continuum of care. Phase 3 focuses on advanced ASAM application and is recommended after completing Phase 2 for providers. It uses complex case scenarios to strengthen clinical reasoning, defensible decision-making, and high-quality documentation. The format, again, is interactive and emphasizes applying ASAM principles in real-world practice. Provider interest has exceeded expectation, with hundreds of clinicians, supervisors, and administrators registering within hours of the announcement. So far, we have held 11 training sessions, 1 for leadership focused on technical assistance strategies, 7 full-day foundational ASAM 4th edition trainings for clinicians across the state, and 3 full-day advanced application trainings. With each session accommodating 50 participants, approximately 500 providers have been trained to date. We are also scheduling 8 additional training opportunities and continue to maintain an active provider waiting list. Next slide, please. We see the clear benefits of this training. It improves clinical decision-making. The ASAM 4th edition provides a more practical and flexible clinical framework, allowing providers to make the real-time decisions with greater clarity. It reduces both over-treatment and under-treatment by improving accuracy and level of care matching. The approach increases provider confidence and strengthens the defensibility of clinical decision. It supports professional autonomy while still offering structured guidance to ensure consistency across programs. We are seeing improved patient outcomes through accurate placement, which enhances engagement and strengthens the therapeutic relationship. Matching individuals to the right level of care reduces relapse rates. It aligns services with a person's changing needs and supports long-term recovery. It also improves integrated care and documentation. Co-occurring treatment becomes a standard approach, not the exception. A shared clinical language decreases fragmentation across the system. Individualized treatment planning is strengthened through clear articulation of risks, needs, and strengths, and documentation becomes more consistent. Next slide, please. To measure the effectiveness, we designed a pre- and post-training evaluation tool with Hazelton Betty Ford Foundation. These tools assess changes in participants' knowledge, confidence, and readiness to implement the ASAM criteria 4th edition. The evaluation design helps us track impact over time, identify gaps, and shape future training priorities. We've seen key improvements from the pre- and post-training. Participants report a significant increase in how well the training prepared them to use ASAM criteria 4th edition in daily practice. Providers show improved ability to serve individuals with higher needs, including people with co-occurring mental health and substance use disorder. Understanding of the ASAM framework has improved in risk ratings, level of care, and multidimensional assessments. Providers report greater confidence in applying ASAM principles in real-time clinical decision-making and documentation. Participants report a clearer understanding of length of service versus intensity of treatment service, supporting more individualized need-based treatment planning. Providers report a stronger alignment of understanding of recovery supports such as housing, peer support, and addressing social determinants of health with clinical needs. There is improved ability to identify required services at each ASAM level of care, supporting accurate placement decisions, continued stays, and transition planning. These evaluation results help us refine future training and content and identify areas where providers still need additional support. The findings are helping us guide the development of additional modules to strengthen statewide implementation. They also inform system-level readiness efforts to help align policies and support collaboration with MCOs to ensure consistent, high-quality implementation across the state. Next slide, please. The vast majority of participants agreed or strongly agreed that they were satisfied with the trainings that we've provided, showing strong alignment that we are meeting providers' needs statewide. This high satisfaction is reinforced by clear post-training improvements. Participants reported feeling more prepared, have a stronger understanding, and better ability to implement the ASAM criteria 4th edition. Overall, the data shows that the training is effective, relevant, and meaningful, strengthening ASAM's implementation across Kentucky. Next slide, please. These are a few quotes from the participants that highlight the real impact of the training, reflecting how providers are already applying ASAM 4th edition with greater confidence and clarity. Feedback consistently emphasizes the value of practical examples, clearer guidance for complex case, and improved understanding of level of care decisions. The comments reinforce that the training is meeting the providers where they are and strengthening their clinical decision-making and supporting more consistent care across Kentucky. Next slide, please. From the Kentucky ASAM 4th edition trainings, we've identified several important lessons. First of all, the demand is strong and collaboration is critical. After launching the training, we met with the MCOs to request support in expanding a number of sessions needed to reach clinical saturation across the state. We are now working closely with the Kentucky Association of Healthcare Plans to coordinate additional training opportunity. Training must be tailored to the audience. We recognize that people of different roles need different levels of depth, different examples, and application to make the training meaningful. Offering separate tracks based on those different roles improve the relevance of the training. We learned that awareness of ASAM 4th edition resources need to be strengthened. Many participants were unfamiliar with available tools, and showing them how to connect to real-world practice supports stronger implementation. We learned that hands-on learning is essential. Interactive exercises, case scenarios, and applied activities significantly increase competency and confidence. We learned that feedback loops matter. Creating structured opportunities for providers to share challenges and questions ensure the training stays responsive and continues to improve over time. Based on the lessons, we've developed some next steps for our training. We are going to continue to collaborate with Betty Ford Hazelton Foundation and the MCOs to expand and sustain training opportunities during the ASAM 4th edition transition. We are also working with Hazelton to prepare for the release of the ASAM Criteria Volume 2 Adolescence and Transitional Age Youth version. It's expected to be released in spring, and we're already working to customize training for that volume. In addition, we are developing focused modules on needs that were identified during the initial training. We are planning a training for forensics that will include our judicial partners, the Administrative Office of the Court, and the Department for Public Advocacy, our public defender statewide system, as well as other criminal justice partners. The second training we are working on is for paraprofessionals that is designed to support peer support specialists and community health workers. We are continuing, based on the lessons learned along the way, to design additional training and refine the training to support the implementation of ASAM Criteria 4th edition across the state. And I'm going to hand it off at this point with the next slide to Angela Sparrow.
Thank you, Sarah. I'll close this out today with a few lessons learned from implementation and transition of the criteria. So as we've exhibited through the presentation today, partners at all levels, as we've discussed, state agencies, our payers, our providers, our community organizations, we know that they're key to success. And so our partnerships, again, they continue to build a foundation, breaking down the silos. Again, it has supported the growth in our transition in Kentucky. So when considering change, for example, again, discussed today in our implementation of the demonstration, transition to the new edition of criteria. So we need to understand, and we wanted to take a step, understand where the gaps are, what the needs are. So from the organization level to the individual level. Kentucky realized, again, we have similarities. Every state agency, every program is different. So meaning the needs are different. There's not a one size fits all approach to change. So again, we did need to consider a variety of different approaches and strategies. And again, this will allow us to continue to sustain change as we transition and move forward. And so again, with that being said, we further know that change is inevitable. And as Kentucky has learned, again, change may come sooner than later. So with transitioning, implementing under the 3rd edition, and then quickly again moving into 4th edition, while we can't predict the future, again, we do try to plan ahead when there's opportunity. We did, again, try to prepare training opportunities where appropriate, support for our providers, our networks. And then again, this allows us to adapt more easily and quickly where needed through the transition. So we do strive again in Kentucky to leverage our resources where available. Again, we're very fortunate to be able to work with our sister agencies and our partners, all who have different strengths, different resources. And then again, those different resources that they bring to the table help us fill the gaps. So working with our sister agencies who's able to support some of the training efforts, training materials that Medicaid typically does not cover, is not able to support, we certainly, again, collaborate together to meet those needs. And so lastly, again, when considering change or transition, we want to keep all partners informed. And this is always one of the keys to partnership and collaboration. And again, it's certainly going to lead to success and a successful change. Hopefully, again, as we continue to transition through the 4th edition, continue to monitor and evaluate across the state. Next slide, please. And so this concludes Kentucky's presentation, and then at this time, we'll open it up to see if there's any questions.
Thank you so much, Dr. Hoffman, Sarah, and Angela. Thanks for sharing your experiences in Kentucky. So now we will open it up for additional questions for the Kentucky presenters. Again, you can use your Q&A chat, that icon in the bottom that says Q&A, or you might have to hit the 3 dots more icon to find it. So our first question for Kentucky, looking in our chat. So same question as we heard in Colorado. So how are you navigating supporting youth serving providers, some of whom presumably also will serve adults, given that the adult system has transitioned, youth text is not yet available? Do you plan to re-engage in the same processes for adolescent programs once the relevant text is available? For example, stakeholder engagement, training, and TA. And have you struggled with infrastructure challenges with 2 versions, e.g. EHR changes and authorization differences? So multi-part question for the Kentucky team.
I'll speak again a little too in terms of on the Medicaid side. Yes, again, we did have to issue clarity with our provider notice and with the communication to our provider network while we were transitioning and have transitioned to the 4th edition. With the youth, again, that is, we are still relying on that 3rd edition criteria until the 4th edition is available. So again, working with our partners, that has been a challenge, working with our MCO. So that has been a challenge. But again, understanding when it comes to those reviews, applying criteria, medical necessity, et cetera, for the youth, again, that is still considered the 3rd edition. The adults, and should clarify that the adults, again, has transitioned to the 4th edition. But as Sarah mentioned, certainly planning ahead, already looking at training opportunities, utilizing, again, same approach, but as we discussed, seeing again where there's opportunity for some changes to better provide that training and support as we roll out the youth edition when available.
That's great, thank you. So our second question that's come in for Kentucky is a 2-part question again. Can you share how you reviewed and adjusted reimbursement rates based on transition to the 4th edition? And second part is, can you discuss what changes, if any, have you made at the provider licensing level?
For reimbursement, again, there were not significant changes at the reimbursement level. Again, still aligning there with some of the levels and the services that we already had in place. In terms of licensure, we are working closely with our Department for Behavioral Health, who also oversees our substance use licensing. So again, working together to align those regulatory changes and licensure changes with, again, some of the language that was initially included in our license and regulations with the initial implementation, really referencing the utilization of the most recent edition of the criteria that allowed us some roadway there, if you will, to support the transition to the new criteria without minimal regulatory changes. And then again, following that up in the year to come with some of those changes that do need to occur.
Great, thank you for that. And I know we have additional questions that have come in. We don't have time to address them right now, but we will take a look and share them back with our state presenters. And thank you, Dr. Hoffman, Sarah, and Angela, for sharing your experiences once again in Kentucky. And I'd also like to thank the team from Colorado, Kristen and Jennifer, for sharing your insights and experiences in your presentations as well. And in a moment, we are going to transition to our breakout rooms for about 15 minutes of small group discussion. Before we do that, I'd like to put in an early plug for our post-event survey. The survey should just take a couple of minutes to complete, but your responses are critical for informing future events to support the implementation of 1115 demonstrations. So we do hope you take a minute to respond to that survey following the webinar. Now, if we can go to the next slide, please. Our breakout discussions. So based on participant interest, as shown in the registration process, we will have discussions about state planning, provider readiness, stakeholder engagement, and monitoring and evaluation. Breakout discussions are not going to be recorded, and team members will join rooms to help facilitate our discussions and capture any key themes. And you are welcome to go ahead and join the room of your choice. All right. Well, welcome back, everyone, and thank you so much for participating in the breakout discussions. I feel like we could always use more time for small group discussion, but we hope you had a good opportunity to meet with some peers from other states and kick off some good discussions there. And we'd like to thank everybody for joining us today in this webinar. And a special thank you for our presenters from Colorado and Kentucky for sharing their experiences and lessons today. We encourage you all to stay connected with the folks that you met in your breakout sessions and continue conversations with your peers and partners as you're moving forward in your ASAM Criteria 4th edition journey. And we'd appreciate your feedback on this webinar. So please do take a moment to respond to the post-webinar survey, which should pop up in your browser as the webinar ends. Your feedback is really critical in shaping future events. So we hope that you can take a minute or two to share your input. Thank you all very much, and I hope you have a good afternoon. Take care.